Today, I'm going to talk to you about electrogastrography and the water load satiety test, especially as we use this to define gastric myoelectrical activity, which then defines patient subsets of disease. I want to especially cover some new developments. In other words, what you need to know in 2023, which is actually what they already knew in the 1920s, but were unfortunately forgotten. Today, we're going to look at what we need to relearn. I'd like to cover the anatomy and physiology of the gastric myoelectrical activity, and in particular point out that we are not directly measuring motility, but actually measuring the electrical energy that is reflected by motility. I want to talk specifically about a new concept known as the ICC motor unit, which is quite important. And one cannot discuss the anatomy and the physiology with, of course, paying homage to the Walter Cannon story, or what we will call 3 pumps, 2 bumps, and a true sphincter. Then I'd like to get into some of the GMA-specific diagnostics where we can link GMA to disease states and subtyping, and how that, along with AI-suggested diagnosis, can lead to disease-based intervention with improved therapeutic outcomes, thereby personalizing and optimizing outcomes, and perhaps changing the diagnostic paradigm. Let's first begin with the most important thing, which is that EGG detects the ICCs of the smooth muscle. And this is the key to motility, but it does not end there. We do know from previous publications that the electrogastrogram is as though you were doing a full thickness biopsy of the stomach muscle, and you would be able to see the number of ICCs, which is normally 5 per high power field. When there is normal 3 cycle per minute activity, we know that there is normal numbers of ICCs, in particular 5 or more per high power field. And when the 3 cycle per minute activity is low or absent, we know that there is either an absence of those ICCs or something that affects what we will now call the ICC motor unit. The ICC motor unit really is an all for one and one for all phenomena. It is made up of the circular and the longitudinal muscle layers, as well as the myenteric neurons, and then, of course, the pacemakers, the interstitial cells of Cajal, discovered by the famous Spanish anatomist Ramon y Cajal, for which he received the Nobel Prize in 1907. These make up a motor unit, and unless all 3 are functioning normally, then you cannot have normal motility or contractility of the stomach. This is a very important point, especially when we talk about the hyponormal or absent 3 cycle per minute activity and the potential etiologies. But first, let's talk about the master physiologist and give homage to Walter Cannon, who published The Mechanical Factors of Digestion all the way back in 1911. Walter Cannon was a master physiologist who, using direct observation of gastric contraction, was able to show us actually how the stomach worked that could explain not only how we can explain disease and why disease occurs, but also what we're actually seeing with the EGG. In particular, we'll call this the 3 pumps, 2 bumps, and 1 sphincter approach to anatomy and physiology. When we look at the stomach itself, of course, we know that the ICCs are the most highly concentrated in the area below the fundus in the proximal body of the stomach, and they give rise to the slow pacemaker settings, usually the serosal 3 cycle per minute slow waves that begin a circular contraction that extend longitudinally. This helps to build the gastric pressure gradient, which is necessary, but only possible in the presence of a normal functioning high compliance sphincter known as the lower esophageal sphincter. This is the first pump, which is in the body of the stomach, as you can see here. Pump number 1. Now, what's interesting is at the bottom of the corpus is the angularis. And just as I have defined one of the highest areas of ICCs being here in the corpus, in the proximal body, the angularis is actually devoid of ICCs and represents essentially a mechanical speed bump. So the food comes down, propelled through the corpus, pressure is developed, and then it runs into that speed bump. So only a certain amount of food can make it into the antrum, which is pump number 2. The antrum is a high compliance, slow motility zone. This is the second pump, and it only contracts at 1 to 2 cycles per minute, as opposed to the lower compliance, higher frequency corpus of the stomach, which is 3 cycles per minute. The antrum then contracts, and the food moves back and forth, moving between 2 bumps, the first bump being the angularis, and then the second area that is devoid of ICCs is actually the pylorus. By the way, the antrum is the highest concentration of ICCs in the digestive system. So thus you have the first pump, the corpus, the second pump, the antrum, the 2 bumps meaning the angularis as well as the pylorus. And then finally, the third pump is in the duodenum. Now, the most interesting thing that Walter Cannon published is that these 3 pumps do not work simultaneously. When the corpus is contracting, the antrum is usually silent. And when the antrum begins contracting as it fills with food from the corpus becomes silent until food enters into the duodenum, or the third pump area. Once that third pump area becomes active, the corpus will reactivate again. And you can see this quite nicely if you look at standard video upper GI barium studies. So again, it's a completely different way of looking at things, but once we understand that the active areas are the corpus, pump 1, the antrum, pump 2, and the duodenum, pump 3, we then understand what we're really seeing in the electrogastrogram and where any particular misfunction or malfunction is taking place. Let me explain further. Here is what the typical summary graph result is when you perform an electrogastrogram. You'll notice here that this is your normal 3 cycle per minute activity in this right upper quadrant box. I will point out to you that the broken red lines represent population-based normal, and the blue line will be your patient result. This, in this case, would be normal. The Brady, and we're changing the nomenclature, and I'll come back to that in a moment, is actually your antral contractions, which run in the 1 to 2 cycle per minute range. They are normally in the normal range, unless there's an absence of the normal 3 cycle per minute activity, in which case it becomes relatively dominant. What we call the duodenal in the lower right-hand side, these are your typical duodenal contractions that occur in the range of 10 to 15 cycles per minute, and very little changes that. And then finally, what we used to call tachygastria, we actually know now that these are re-entry rhythms that begin in the absence of the normal 3 cycle per minute pacing, that they take over as pacemakers, and again are seen dominant only when there is an absence of 3 cycle per minute activity. Now here is where these 4 graphs correspond to with regard to the stomach. Again, you'll remember the first pump is here in the corpus, and this is where you find the dominance of your 3 cycle per minute activity. Your second pump, which is down in the antrum here, is this slower wave activity. Here is your duodenal, which is your third pump. And then finally, the tachygastria, which are your re-entry rhythms that occur only in the absence of the 3 cycle per minute activity. So what we are seeing when we look at an electrogastrogram and its result is exactly what's happening with each region of the stomach, which helps us to understand both health as well as disease. Now, I mentioned that we're going to talk about some of the new things in 2023, and in this particular case, we're talking about the revised nomenclature. So again, the body of the stomach, which is pump number 1, are your corpus contractions, and that is where you see the normal 3 cycle per minute activity. Antral contractions, we call the gastric slow waves. They are actually quite dominant because they slow digestion down because there's only contractility in 1 to 2 cycles per minute. Now, those are typically seen as dominant only in the absence of 3 cycle per minute activity. This is formerly what we used to call bradygastria, and you will see these changes start to take place in your reports in some of the newer versions. Of course, your duodenal contractions we've talked about, this would be pump number 3, and that would be 10 to 15 cycles per minute. And then finally, what we used to call tachygastria, these are really your gastric pacemaker reentry contractions, only seen dominantly in the absence of 3 cycle per minute activity and occurring in the 4 to 10 cycle per minute activity range. These are ineffectual type of contractions leading to poor emptying or poor motility in the corpus of the stomach. Now, when we put all of this together, we're trying to subtype disease. And we do that by focusing on the normal corpus, because this is where we have the majority of the knowledge base. We subtype into either the normal 3 cycle per minute activity, the hypernormal 3 cycle per minute activity, which you can see manifested as the patient results above the broken red lines, or the hyponormal, indicating some dysfunction of the ICCs or the ICC motor unit. This helps us focus not only on diagnostics, but also on therapy. When we look at a patient, whether they have gastroparesis or whether they have dyspepsia, because we now know from the National Institutes of Health studies and over nearly 1,000 patients that these are both the same disease, and they're both manifested as problems with the ICC or the ICC motor unit. If we look at the patients in the hypernormal group, these represent typically 20 to 25%. Because they're in the normal or hypernormal range, we know that this means that the ICCs are in the normal range of 5 per high power field. And we also know that this is due to something known as functional pyloric outlet obstruction. You can also see it in mechanical outlet obstruction, but typically that's easy to see endoscopically. The functional outlet obstruction you will only find using EGG. These things respond to pyloric therapy, either surgically at about 78% or using balloon dilation therapy with a 20 millimeter TTS balloon. And usually there's a permanent response at 93%. Those patients that fall in the normal range of normal 3 cycle per minute GMA, we also know have normal ICCs of greater than 5 per high power field. This is approximately 40 to 50% of the population. And here we can further subset these patients based upon their symptoms. Now, you will recall I mentioned that controlling all of this, that is very important because you have to maintain a gastric yield pressure, is that high compliance lower esophageal sphincter. And if those pressures if that sphincter is insufficient to maintain the pressure, then you can actually have the development of dyspepsia or gastroparesis because of the presence of reflux. And in publications, we see that whether it be an endoscopic correction of reflux or a surgical correction of reflux, we see resolution of the GERD and the dyspepsia in up to 85% of the cases with correction of the GERD. Those patients who do not have reflux dominant symptoms, this is typically going to be due to poor contractility. You'll usually see a lot of tachygastria in these patients. And these are the ones who we expect to respond to meds, sometimes to pyloric therapy, and sometimes to pacemakers such as Entera, in up to 72% of these cases. Now, a very special group are your hyponormals. In this case, we suspect that there must be less than 5 per high power field of ICCs, or there is dysfunction of the ICC motor unit. Now, this can be between 25 and 40% of patients. What we begin to do at this point then is to look into the patient's history and say, do we have a problem with ICC insufficiency, deficiency, or malfunction? Or do we have something that's myogenic in etiology or neurogenic in etiology? And when I talk about myogenic or neurogenic, so for instance, infections such as COVID or other viral infections will create a neurogenic defect. In other words, the vagus nerve or other myenteric neurons are affected by infections, and this can therefore lead to non-operability of the ICC motor unit. It can be metabolic. It can be due to endocrine conditions also. Now, with regard to the muscle, if we have collagen vascular disease, such as scleroderma, with fibrosis and thickening of the muscle, that would be affecting the muscle as part of the ICC motor unit, and that would be your underlying cause for poor motility. Other conditions, such as connective tissue disorders like Ehlers-Danlos or loose joint syndrome, can also do the same thing, as well as endocrine conditions like diabetes. Now, diabetes is very special because you can have one of two things happening with diabetics. In poorly controlled diabetes, there can be poor microcirculation, in which case these patients may respond to something like oral nitrous oxide to rebuild the circulation, and we may see then, therefore, improvement in the EGG and improvement in the contractility. In other cases, it's actually because of a disorder of an imbalance between the M1 and the M2 macrophages. And so with control, restoration of diabetic control, then what we end up seeing is a rebalancing of the M1, M2 macrophages, and therefore a decrease in the inflammation of the ICC motor unit and a restoration of function. Again, hyponormal is always a reason to look for the underlying disorder and try and fix it. If you cannot fix it, these are some of the most difficult cases because they will not respond to surgical therapy. They are typically not going to respond to gastric stimulators or vagal stimulation either. Oftentimes, if it's infection, this will improve on its own. I thank you very much for your attention, and please enjoy the rest of the meeting. Thank you.